Dr. Diji S, going to present a case study on Calcaneal Spur and its Ayurvedic correlation, Ayurvedic management and its correlation is Vada Anagha. So first let's move on to its definition. Calcaneal Spur, or commonly known as heel spur, occurs when a bony outgrowth forms on the heel bone. Calcaneal Spur can be located at the back of the heel and it is termed as dorsal heel spur or under the soil, which is termed as plantar heel spur. The common site of spur formation are insertion of Achilles tendon on the posterior margin of the calcaneus, and the second one, the attachment of plantar aponeurosis on the inferior surface of the calcaneus, and these are the sides. This is the plantar fascia and this is the Achilles tendon. The Achilles tendon and plantar fascia are both attached to calcaneum. If the spur is formed at this side, it is termed as dorsal spur, and if it is formed at this side, it is okay. Prohibition in long standing down. In case of long standing down, the uric acid crystal will accumulate in the joints, and further accumulation will result in tear, Achilles tendon or plantar fascia, which leads to calcification and leads to spur formation. Then pes callus, which is also termed as high arched foot, or pes planus, which is termed as flat foot. Obesity, as weight increases, vertical compression increases, and it leads to formation of calcaneal spur. Pathophysiology, any initial injury and followed by repetitive stress, walking, running on hard surface, which causes microtear, plantar fascia or Achilles tendon, leads to any healing process, fibroblastic activity to heal the soft tissue, which results in bone formation. If the injury persists, the body recreates the osteoblast to lay down new bone at the site of stress, mainly at the attachment of plantar fascia or Achilles tendon to the calcaneal bone, and it leads to calcaneal spur formation.
Types of calcaneal spur. There are two types of calcaneal spur. One is dorsal spur, which is associated with Achilles tendon, and the other one is plantar spur, which is associated with plantar fascia. Pathophysiology of dorsal spur formation associated with Achilles tendonitis. Breakdown of the tendon fiber where the Achilles tendon connected with the calcaneum. Then calcification of damaged fiber, dorsal heel fiber, spur formation. Pathophysiology of plantar spur formation associated with plantar fasciitis. Chronic stress and micro tear in plantar fascia, which triggers the body response. Calcium deposits at the site of injury to heal. Deposit solidifies and form a bony outgrowth on the heel bone, and finally forms calcaneal spur. Types of plantar spur. There are two types of plantar spur also, type A and type B. The type A spur are superior to plantar fascia insertion. In type B, the spur extends forward from the plantar fascia insertion distally within the plantar fascia. The type A is longer than type B, but the type B is more painful. This figure shows the type A and type B. Clinical symptoms. Main symptom is talgia, which means heel pain. Anterior dorsiflexion will be more painful in the case of calcaneal spur due to biomechanical heel cone tightness. Pes planus, which means flat foot, patients more affected than pes callus, which means arched foot. Heel pain often sharp or stabbing in nature, especially during the first step in the morning or after rest. Tender bony lumps on the palpation of heel also present.
Next, clinical examination. Inspection of the heel for swelling or other signs of inflammation like redness, and also check the foot for any abnormalities at rest and while diagnosing. Next one, palpation. By gently pressing on different parts of the heel to locate the source of pain, noting any tenderness or the bony prominence. Medical history. A detailed medical history Then a specialized test. Actually, it is conducted in case of plantar fasciitis, but it can also be done to rule out calcaneal spur. It is also termed as windlass test, jack test, or plantar fascia flex test. Usually performed to assess plantar fascia and its connection to heel pain, which is often associated with calcaneal spur. It can be of two types, weight-bearing windlass test and non-weight-bearing windlass test. In weight-bearing windlass test, the patient stands with toes on step or block, heels hanging off. Clinician passively dorsiflexes the big toe for the first metatarsophalangeal joint and observes for pain or discomfort in the medial heel region. The next is non-weight-bearing windlass test. The patient sits with legs hanging freely and the clinician stabilizes the ankle and dorsiflexes the big toe. Check for pain or tightness under the arch or heel. Can be demonstrated through the video.
Morning breakfast with fruits. Badam, seeds. Idilum, ragi, wheat, corn, raisins, macadamia, cranberries, milk, curd, then 100 kilos muesli, 12 grains, fruits, nuts, seeds, and whatever pomegranate mustard kilos muesli, which is one for breakfast.
First metatarsophalangeal joint in standing position, that means in weight-bearing position. And in case of calcaneal spur or plantar fasciitis, the patient will experience pain in that region, heel region. This is a not weight-bearing position. Same procedure in two different positions. And the same weight-bearing position. Here. The investigation technique are X-ray, which is the key diagnostic technique. Usually, calcaneal spur can only be diagnosed by using X-ray. Clinical examinations are only just. Okay. Then MRI, it is directly used. Then CT, and then USG. The key diagnostic tool for plantar calcaneal spur is X-ray. Okay. Can only be confirmed through X-ray. This shows the arrowhead indicate plantar calcaneal spur skeleton. The first figure A shows skeleton's lateral view and figure B shows skeleton inferior view. This one. And this first figure shows sagittal medial MRI of calcaneal spur and it is here. And this figure shows lateral foot X-ray of calcaneal spur. These all are the investigation techniques. The main technique is X-ray. Then differential diagnosis. The musculoskeletal can be divided into three: musculoskeletal causes, traumatic influences, and neurological causes. The musculoskeletal causes. The first one is peroneal tendonitis. It means the inflammation of one or both peroneal tendon, and it can be differentiated through MRI or USG. The second one is Hoagland's deformity, with or without bursitis, and it can be differentiated through radiograph, sonography, or foot in maximal dorsiflexion position. Then Sever's disease or calcaneal upper fasciitis, inflammation of the calcaneal upper fasciitis due to overloading, and it can be differentiated through clinical ESG. In Calcaneal Spur test, the patient is seated or standing. The examiner holds the key with fingers on the medial and lateral sides of the calcaneus, applying firm cues, medial lateral compression to the calcaneus, and note if the patient report localized heel pain or not.
നിങ്ങൾക്ക് സഹപ്രവർത്തകർ തന്നെ അവരുടെ സെക്യൂരിറ്റി നോ ചാൻസ് അതുകൊണ്ട് ബോഡി ക്യാപ് ഫ്രീ ബയോഗ്രാം ഇതിന്റെ സുപ്പീരിയർ ഇൻസുലേഷൻ ഇമർജൻസി ബോഡി ക്യാപ് ഫ്രീ ബയോഗ്രാം ഇതിന്റെ സേഫ് ഹാബിറ്റ് ആക്ഷൻ
The patient is positioned in supine. The therapist taps
It shows the renal sign.
tibial nerve posterior to the medial malleolus. The test is positive if it elicits pain or tingling in the distribution of the tibial nerve. The patient is positioned in supine. The therapist taps repeatedly on the tibial nerve posterior to the medial malleolus. The test is positive if it elicits pain or tingling in the distribution of the tibial nerve. The patient is positioned in supine. The therapist taps repeatedly.
The next one is dorsiflexion eversion test.
Eversion test evaluates for tarsal tunnel syndrome. The examiner passively brings the foot and ankle into full dorsiflexion, everts the heel, and maximally dorsiflexes all the toes. A positive test is indicated by reproduction of the patient's symptoms. The dorsiflexion eversion test evaluates for tarsal tunnel syndrome. The examiner passively brings the foot and ankle into full dorsiflexion, everts the heel, and maximally dorsiflexes all.
So calcaneal Spur test is performed to rule out whether it is severe disease or calcaneal spur. Then next one is traumatic influence. This can be a calcaneal fracture. Then the another one cause is neurological causes, which can be Baxter nerve entrapment disease. It means chronic compression of the first branch of the lateral plantar nerve, and Tinner sign will be positive in this case. The next one is tarsal tunnel syndrome, impingement of the posterior tibial nerve, and it can be differentiated by Tinner sign and dorsiflexion eversion test, which was demonstrated. The conservative management for calcaneal spur are padding and strapping of the foot, therapeutic orthotic insoles for short-term pain relief, Achilles and plantar fascial stretching, nail springs, physiotherapy, cast or boot immobilization, ESWT, extracorporeal shockwave therapy, and bipolar radiofrequency.
And the Ayurvedic correlation of calcaneal spur is Vada. निदानकाल संप्राप्ति रुक्पदे विषममन्यस्ते श्रमद्वा जायते यदा वादेन गुल्फमाचित्य तमाहुर वादकण्डः. Placing the foot improperly while walking, overexertion to the feet, visually vada localized in gulfa, produces pain in the gulfa pradesh, causes vadakandha. चिकित्सा सूत्र for vadakandha. रक्तावसेचनं कार्यम् अभीष्णं पादकण्डके पिबेत् एरण्डतैलं वा दाहेत् सूचिभिरेव वा. The Chikitsa Sutras are frequent Raktamoksha, Eranda and Aktikarma with Suji. Treatment approaches. A. To reduce tenderness, pain in the right heel. Presently complaint. Patient complains of pain in the right heel since 2 years. History of presenting complaint. A 65-year-old non-diabetic patient weighing 95.5 kg with BMI 37.8, obese class 2. Presents with a 2 to 3 years history of heel pain, predominantly localized to the dorsal aspect compared to the plantar aspect, with recent exacerbation over the past 2 weeks. The symptomology is characterized by a pricking type of pain, typically aggravating after nocturnal rest, and precipitated by activities such as standing up from a sitting position, lifting heavy weights, example, a bucket filled with water, and prolonged standing. The pain usually subsides after adopting resting position. Nocturnal pain is also experienced intermittently. Exacerbations are accompanied by localized signs of inflammation, including marked redness, edema, and tenderness with concomitant temperature changes. Notably, there are no palpation or visible bony projections outside. Previously, she had consulted an allopathic physician and was told to take an X-ray which revealed the presence of calcaneal spur in both dorsal and plantar aspects and was suggested to have a surgery which she refused. Currently, the ankle joint exhibits a painful range of motion since the pain was unbearable in such a way that she can't stand due to severe pain, so she came to our OPD for better treatment. Initial assessment. Inspection. Redness. Present when there is pain. Edema. Present when there is pain. Any projections at the site? Absent. Palpation. Tenderness present. Temperature present if there is edema. Medical history. Type of pain is pricking type. When it started? 2 years back. What makes it worse? Standing, walking, weightlifting, pain often, sharp or stabbing, especially during first steps after the morning or after resting. Patient's footwear was accustomed to use footwear with cushioned sole and arch support. Range of motion, whether affected or not. Dorsiflexion, plantar flexion, inversion, eversion are the range of motion of ankle joint. And in this case, all the R1 are possible with pain. This is the X-ray of our patient showing both calcaneal spur on the dorsal and also in the plantar. Internal medication. Gugulu Tikkatu Kashayam and Kaishwara Gugulu as internal medication. Then Panchakarma therapies, Dhanyamla Dala full body on the first day, Upanama Svedam on the first and second day, Ksharadasya on the second day, and Ektamokshana and Agnikarma on the third day. Assessment after treatment. Inspection. Redness and edema reduced. Palpation. Tenderness and temperature reduced. R1. Severity of the pain reduced. Effect of treatment. Dhanyamla. Vada is Vada Kapuja. The Ushna Guna of Dhanyamla pacifies the Shida Guna of Vada, while the Ruksha Guna balances the Kapha dosha. And it reduces the pain and inflammation because it is anti-inflammatory, and also it helps with Ama Vajana. The application of warm Dhanyamla improves local blood circulation and enhances the metabolism in the affected heel region, which aids in the tissue repairing and overall healing. Alleviates the stiffness by reducing Svedana property. Then the Ksharadasya. Vata and the Kapha pacification. The inherent Ushna Guna and the Tishna Guna of the Kshara, which directly opposes the Shida and Sthira quality of Vata and Kapha. Effectively reduces the pain and stiffness. Srodha Roga elevation, which means clearing the obstructions. The condition involves Srodha Roga due to the accumulation of Ama and vitiated dosha in the heel region, and the penetrating property of the Kshara helps to clear these obstructions, ensuring proper circulation and nutrient supply to the affected tissue. Anti-inflammatory and analgesic effect. The Kshara contains property of Shulahara and Shodhahara. Rasayana. Ingredients commonly used in Vasti preparation such as Shira and Gruda helps to nourish the Asthidhatu and surrounding structures, promoting the healing and preventing reoccurrence of this condition.
The next one is Upanahas Veda with cotton chukati and dhanyamala. Cotton chukati is used since it is Svadhara and Guna. Then Rektamochna and Agnikarma was performed in this patient. Rektamochna by Sira Vedana as Purva Karma Abhyanga with Tilataila followed by Nadi Sveda. As Pradhana Karma, patient placed on a couch and affected foot placed on stool below. Cuff of the BP apparatus applied over the affected leg and inflated to make the leg prominent and enlarged. Sira Vedana is done with the help of suitable scalp weight from the region of the affected leg at 2 angula above the Shikramarma. This is the Shikramarma. Medial as medial metatarsal vein, which is a branch of dorsal venous arch, is present here. Sira Veda is done till the bleeding is stopped by itself or a maximum of 30 ml of blood is drained out. Continuous observation is made for any Padmagada or any other adverse event. Paschat Bandhana is done at the site of Sira Vedana. Bed rest for at least half an hour. Light is allowed to take after 1 hour of Sira Vedana. The next procedure was Agni Karma. As Purva Karma, the heat area is cleaned with distilled water and wiped with dry sterilized clothespieces. Most painful sites are marked with marker. Pradhana Karma, Bindu end of Shalaga will be placed on the site of heat plate. After heat sensation, Shalaga will be removed and placed on the other side of pain and tenderness. Immediately after Agni Karma, Murivanna applied on the site to avoid burning, scar and other adverse effects. The image is not of, this image doesn't show our patient, it's just a reference image from an Ayurveda article. Then the other internal medicine used was Gugulu Pippalo Kashaya. As it is Vata pacifying, anti-inflammatory, tissue regeneration and bone health, Strodha Shodhana and promotes healing. The next one was Kaishora Gugulu. Reduces pain and inflammation. It contains Ayurveda as an ingredient, as Ayurveda Ayamana is mentioned as a treatment of Vata Kandana. According to the mentioned Chikitsa Sutra, there will be indirect consumption of Ayurveda Taya through Kaishora Gugulu. Sinhanada Gugulu can also be used. Okay, then this is the end of our presentation.